In the breathwork world, there is a study that is quoted all the time, which is humming produces about 15 times more nitric oxide. Are you familiar with that study?
In terms of biochemistry, there's certain frequencies, and so we're energetic beings. And so what we know is that the frequency resonance is dependent upon the volume. So everybody has a different volume of their nasal cavity, their oral cavity. But this resonance frequency that can release nitric oxide or produce nitric oxide is dependent upon the volume. So humming creates a certain frequency and a resonance that can recapitulate that. But again, if you can't make nitric oxide or your enzyme isn't working, then humming cannot stimulate or activate nitric oxide production, nor can it release nitric oxide bound to metals or cysteine thiols, because if you're nitric oxide deficient, there's less kind of labile stores of nitric oxide to be activated either by light or by humming frequencies.
Dr. Brian, thank you so much for coming on the Take a Deep Breath podcast. I'm so excited to pick your brains today all about nitric oxide. I wonder if we could just start with just a little bit about like your background and your credentials. So anybody that doesn't know who you are, we know straight away like with the authority that we've got with us today.
Well, thanks, Mike. Great to be with you. I'm a small town Texas boy. Got a degree in biochemistry from the University of Texas at Austin. After that, I went to LSU School of Medicine. I completed a PhD in molecular and cellular physiology. I did my training at Boston University Medical Center and the Cardiovascular Institute. But really, everything I've done for the past probably 25 or 30 years now has been, all on researching the understanding and production of nitric oxide. And then after Boston, a fellowship in at Boston University School of Medicine, I was recruited to join faculty at University of Texas Medical School in Houston at the Institute of Molecular Medicine, which was part of the Department of Medicine then. But I was recruited by the guy who won the Nobel Prize, Fred Murad. He had a strong department there in nitric oxide and, was obviously familiar with our work and publications. And so, I was fortunate to, work under the guidance and leadership of Dr. Murad for a number of years, where we were singularly focused on trying to understand how the human body makes nitric oxide, what goes wrong in people that can't make it, and then how do we correct that. So that's been past 30 years of my life.
Wow. And could you just explain for us, like, why did those people win the Nobel Prize for nitric oxide? What in a nutshell, what was so interesting about that, and what caused the kind of the accolade to come to them?
Well, the Nobel Prize was awarded for the discovery of nitric oxide as a signaling molecule in the cardiovascular system.
Mhm.
And so collectively, there were three U.S. scientists, Bob Furchtgott, Fred Murad, and Lou Ignarro, who shared the Nobel Prize. But these were three independent research groups that really made some seminal discoveries on their own that when you put the pieces of the puzzle together, it really told a beautiful story. So in 1977, Dr. Murad published that drugs like nitroglycerin that had been used for 100 years prior to the 1970s worked because they were metabolized into nitric oxide. They activated an enzyme in the smooth muscle that led to smooth muscle relaxation and vasodilation. So they opened up the blood vessels of patients with ischemic heart disease. And then, so that was 77. In 1980, Bob Furchtgott, who was a pharmacologist at State University, New York, discovered that our endothelial cells, these are the cells that line all blood vessels throughout the body, when activated, produced a substance that causes blood vessels to relax. And he didn't know what this substance was. So in this 1980 Nature paper, he called it endothelium-derived relaxing factor, right? So it's a factor that relaxes the smooth muscle, dilates blood vessels, and is produced by the endothelium. And then, still today, is probably one of the most important discoveries in vascular biology. And then it took 7 years approximately to discover or to realize that EDRF, described by Bob Furchtgott, is actually nitric oxide gas. So now when you understand the discoveries of Lou Ignarro, Fred Murad, and Bob Furchtgott, the picture becomes extremely clear that whether you give a nitric oxide releasing agent, a nitric oxide active drug, or you stimulate endogenous nitric oxide production, it signals the smooth muscle to relax and dilate the blood vessels. So now we're going to improve oxygen delivery, improve perfusion to every organ, tissue, and cell in the body. So that was what started this entire field, which began in the 70s, Nobel Prize in 1998. here we are 27 years later, we have a pretty good understanding of nitric oxide production and signaling in the human body.
Yeah. What I'm really excited about today is to jump into a bit of the breathing first with you, talk
yeah.
about breathing and breath work, and then maybe we can go into oral health. And there's so many places I want to go with this. But what I would love to know, first of all, is can you talk about nasal nitric oxide and how that differs, if it does, and why it's produced in that area?
Well, we have to go back again to the 1980s, late and early 90s, when these nitric oxide synthase enzymes, so they were first cloned and identified back then. So we have what's today is 3 isoforms of this enzyme, nitric oxide synthase. And we used to call them eNOS, nNOS, and iNOS for endothelial nitric oxide production, neuronal nitric oxide production, and inducible nitric oxide synthase for based on the cell in which they were first identified and cloned. But today we call them NOS1, NOS2, and NOS3, because we know that their eNOS is found outside the endothelial cells, and similar nNOS found outside of neurons. But the identification and really the elucidation of the mechanism of how these enzymes work, they're what's called homodimers. They come together, and then when activated, they convert arginine to nitric oxide. Then that nitric oxide dilates the blood vessels. Or, in the case of nasal breathing, the bronchioles. So whether it's a blood vessel or a bronchiole, they're surrounded by smooth muscle. So when smooth muscle relaxes, it dilates the bronchioles or the blood vessels. So the same enzyme that's found in our endothelial cells is found in our epithelial cells in the upper airway. In fact, the entire airway. So when we do nasal breathing, so there's mechanoreceptors on the epithelial cells that when activated, they produce nitric oxide. Or the epithelial cells produce nitric oxide. And then we dilate the bronchioles, we deliver that nitric oxide into the lower airways, we improve oxygen uptake, oxygen delivery, we dilate the pulmonary arteries, so now we can match ventilation to perfusion, and we get really optimal, sufficient blood oxygen saturation and oxygen delivery, even in the systemic circulation. So that's how it's normally designed to work. That's normal physiology. The problem is in people who develop endothelial dysfunction, so the enzyme, the nitric oxide synthase enzyme, becomes dysfunctional. Right? Oxidative stress leads to uncoupling of the enzyme and can no longer produce nitric oxide. So now if you don't have a functional NOS enzyme and you do nasal breathing, you're not going to get any nitric oxide produced because we have to fix the function of the enzyme. And we and others have been able to demonstrate this, that we certainly know that the older you get, the less nitric oxide you're making in the lining of the blood vessels. And we can detect that through something called flow-mediated dilatation. We can also detect the function of the enzyme in the upper airways, and the amount of exhaled nitric oxide that we're seeing through nasal breathing. So young, healthy people, nasal breathing, even humming, for example, can produce nitric oxide gas. But if the enzyme becomes uncoupled and dysfunctional, we detect less nitric oxide through nasal breathing in the exhaled breath. So it's diagnostic for a dysfunctional enzyme. So nasal breathing is extremely important, but we have to primarily focus on the function of the enzyme so that we're getting optimal nitric oxide production when we're doing nasal breathing.
Yeah. And what would improve the nitric oxide production in the nose, and what would make it worse? So, for example, people use steroids when they've got hay fever. So, what's affecting it? And what role does the microbiome of the nasal passage play in nitric oxide production?
Well, both of those are playing an extremely role. So steroids suppress protein synthesis, right? So they shut down the body's immune response, and they're pretty good at masking symptoms. But long-term use of steroids, can obviously people aren't getting better on steroids. Many times they're getting worse, and so we have to constantly be able to express and transcribe and translate a functional nitric oxide synthase enzyme. So the same conditions that lead to endothelial dysfunction, again, a poor diet, high glycemic index, a lot of sugar, that leads to NOS uncoupling and oxidation of the enzyme in the blood vessels, leads to oxidation and dysfunction of the enzyme in the upper airways and the epithelial cells. So it's primarily driven by diet and lifestyle. And then the microbiome is extremely important, not just the oral microbiome, but the microbiome in the upper airways, then we were finding that there's nitrate-reducing bacteria and even ammonia-oxidizing bacteria that can produce nitric oxide from either nitrate or ammonia. And so the absolute worst situation for any given human is mouth breathing, right? Because we're bypassing the nitric oxide producing pathways of the nasal epithelium, and we're inhibiting that pathway if we do nasal breathing. Because when we mouth breathe, it completely oxygenates the oral cavity. The mouth is not designed as a breathing instrument. It's a speaking instrument. And so when we do now mouth breathing, we're bypassing the nasal breathing. We're completely changing the ecology, causing dysbiosis in the oral cavity. And we and others have discovered that if you have oral dysbiosis, it leads to chronic nitric oxide deficiency. Your blood pressure goes up. You lose the protective benefits of exercise. And you start on this very slippery slope of rapid onset and progression of chronic disease.
Wow. So just another reason to shut our mouths and nose breathe. So in the breathwork world, there is a study that is quoted all the time, which is humming produces about 15 times more nitric oxide. Are you familiar with that study?
Yes.
Yeah. Okay. So what I would like to know is why and how. Like, why does vibrations do this? And if it's doing it in the nose, is there other ways to vibrate the body to do this as well, or is it unique to the nose? So if you could talk through that a little bit.
Yeah, look, in terms of biochemistry, there's certain frequencies, and so we're energetic beings, and so there's frequencies that activate nitric oxide production. There are frequencies that release nitric oxide that's bound to metals, that may be bound to proteins, particularly sulfur residues on sulfur molecules on cysteine residues. So what we know is that the frequency resonance is dependent upon the volume, right? So everybody has a different volume of their nasal cavity, their oral cavity. But this resonance frequency that can release nitric oxide or produce nitric oxide is dependent upon the volume. I mean, that's basic kind of physics. So, but again, there's two pathways. You can stimulate nitric oxide production from the nitric oxide synthase enzyme, but again, that's dependent upon the function and the activity of the enzyme. Then two, there are other certain frequencies that can release nitric oxide bound to metals, for example. And we know that infrared light, probably the entire spectrum of infrared radiation or frequencies, can release nitric oxide bound to metals. And again, it's frequency. So humming creates a certain frequency and a resonance that can recapitulate that. But again, if you can't make nitric oxide or your enzyme isn't working, then humming cannot stimulate or activate nitric oxide production, nor can it release nitric oxide bound to metals or cysteine thiols, because if you're nitric oxide deficient, there's less kind of labile stores of nitric oxide to be activated either by light or by humming frequencies.
And how would you know? How would one know if they were deficient in producing nitric? What would the test be, or how would you work that out?
Well, I mean, unfortunately, there's not blood tests or anything we can do clinically. I mean, in the research lab, we do blood draws and look at different metabolites of nitric oxide, but clinically, it's not used. So we have to rely on symptoms. And today we understand there's a hierarchy of symptoms that develop as a consequence of different degrees of nitric oxide deficiency. So the first one, we call it the canary in the coal mine, is erectile dysfunction. So if you have any type of erectile dysfunction, either severe or mild, that tells us that your body's not making nitric oxide. Because to get an erection in both men and women, we need to dilate the blood vessels of the sex organs, right? And we do that through the production of nitric oxide. So if the enzyme in the lining of the blood vessels can't produce nitric oxide, you can't get vasodilation, you don't get engorgement, and we call that erectile dysfunction. So that's number one. Number two, you start to see an increase in blood pressure. And 2 out of 3 Americans have an unsafe elevation in blood pressure. I think those statistics are probably, similar in other areas of the world. And so if you can't dilate the blood vessels systemically, now you've got the same volume of blood going through smaller pipes, and simple physics tell us that pressure goes up. So again, any 1 millimeter increase in blood pressure, 1 millimeter of mercury increase in blood pressure above 120/80 increases your risk of vascular disease by 1%. So if you've got a blood pressure of 140/90, you've just increased your risk of cardiovascular disease by 20%. So we have to focus on the restoration of nitric oxide. Number 3, you start to get metabolic disease. because nitric oxide production is required for normal insulin signaling. So insulin resistance is a symptom of nitric oxide deficiency. And we have to change the conversation on insulin resistance and metabolic disease. It's a consequence and a symptom of nitric oxide deficiency. And then number 4, you start to get exercise intolerance. If you can't walk up a flight of steps or take a 15-minute brisk walk without getting short of breath or tightening of the chest, then that tells us you're nitric oxide deficient. And then 5thly, you start to develop mild cognitive impairment. There's loss of perfusion to the brain. You get dementia, and eventually you get Alzheimer's. So those are the really 5 signs and symptoms of the progression of nitric oxide deficiency. And it starts early on, sometimes in your 20s. There's 20, 25-year-old kids who have erectile dysfunction and have to be treated with drug therapy for ED. And it's because their body's lost its ability to naturally produce nitric oxide.
What's causing that loss? What are the is it a modern problem, or is it something you mentioned, age-related decline? So just walk us through, like, what are the things that are guilty of creating this loss in us? Just going to pause the podcast for a second. I'm super excited to share that our 7-day breathwork reset program, or burnout reset program, is for a limited time completely free. I've been running this course for about a year. We've had amazing results, and it's designed for you if you are tired and exhausted and you've got no time. So the less time, the better. It's only 7 minutes a day, this course, and it's a 7-day program, and it's designed to build habits, healthy, sustainable habits using the breath. And so I wanted to make it accessible to you for a period of time. Thank you for being here. Thank you for watching this podcast. So the link's down below. It's a professionally edited and put together course. It's all held in a lovely place, and you get to keep it for life as well. So grab the link below, and my suggestion is this: if you're going to do it, then do it. Don't put it off. Don't grab the link and think, I'll do that next week. It's only 7 minutes. So I would get the link, and then after this podcast, after you finish watching it, get signed up, get enrolled, and just do the exercises that I send you each and every day and have fun with it. And I promise you, at the end of the 7 days, you'll be a different person to who you are watching this video right now. So the link's down below. It's only free for a limited time. It's usually about $77 to $97. We play with the price a little bit, but I wanted to give you a little gift. So link's down there, grab it, and let's get back on with the show. Cheers.
Well, to answer that question, we first had to understand, how does the human body make nitric oxide? Because if we don't understand mechanism, we can't we don't know how to fix it if we don't understand how it normally is produced. So there's an enzyme we talked about, the nitric oxide synthase enzyme, and then there's the bacteria that's fueled through diet. So what's leading to a loss of nitric oxide production? It's the modern diet, what we call the SAD diet, the standard American diet, which now I think has become, in most westernized industrial nations, there's this standard diet that's replete with sugar, high glycemic index foods, processed foods, and seed oils. And so all that is leading to an oxidation of the enzyme and leading to endothelial dysfunction. And then it's also contributing to oral dysbiosis. Things like a poor diet, things like fluoride in your toothpaste, which is an antiseptic killing the microbiome. Use of antiseptic mouthwash, completely destroying the microbiome, shutting down nitric oxide production. And then I think the biggest contributor is antacids, specifically the proton pump inhibitors, the Prilosec, Prevacid, Nexium, Omeprazole, Pantoprazole, that many people are taking, even without a prescription. You can get these drugs over the counter now anywhere in the world, at a drugstore, at any store. You can buy these drugs over the counter. So what we're finding is that people who have been on these drugs for 3 to 5 years have about a 40% greater risk of heart attack, stroke, heart attack, stroke, and Alzheimer's. And we know mechanistically that they completely shut down nitric oxide production. So it's modern living. It's poor diet, lack of physical exercise, drug therapy, and poor oral hygiene, and exposure to fluoride, cholesterol-lowering medications, acid suppressors. All of that completely shuts down nitric oxide production.
There's too many areas I need to get into. What are your thoughts on swimming pools and chlorine in the water? What would that be doing?
It's an oxidant. If you go back to your high school chemistry course and look at the periodic table, chlorine, fluoride, bromine, iodine. These are called halogens. They're at the far right of the periodic table next to the noble gases. These are the most electrophilic, meaning electron-loving molecules on the planet. And electrophilic means they love electrons, so they steal electrons. And in biochemistry and in kind of physics, we know that anything that steals an electron causes oxidation. So an oxidation is a loss of an electron. A reduction is a gain of an electron. So in biochemistry, we figure out the transfer of electrons and we count electrons. So anything that steals electrons leads to oxidation or rust. So we become, if you leave metal out in the environment, right, it oxidizes, it rusts. Well, it's because it's losing electrons. And that's what happens inside our body. We rust from the inside out when we have electron stealers in our body. So fluoride it's an electron stealer and leads to oxidation. Chlorine in pools is an oxidant. That's why they put it in there. It creates an oxidative environment that kills bacteria and algae and growth that you don't want in the pool. But these are very small molecules and they're absorbed transdermally. So chlorinated pools are extremely dangerous and bad, and I completely avoid them. And fortunately, I've raised my kids to where when they go to their friend's house, they will not jump into a chlorinated pool because they know the dangers of it. And when you avoid chlorine, you can smell it. When I go to the gym in Lifetime, for example, it's like walking into a chlorine gas chamber. You smell it, and it's bad news.
Wow. So you wouldn't let kids in the pool? You just think that's
Absolutely.
too dangerous? Wow.
No, I have a pool at my home, but it's a chemical-free, non-chlorinated pool. We use
Right.
ozone and UV light, but it's not chlorinated. It has a redox potential of an ORP, what we call an oxidation reduction potential of about 900. So it's donating electrons and it's leading to improved tissue oxygenation, but no chlorine, no chemicals whatsoever in there.
Jeez. And there's a hot topic at the minute of microplastics. Is there any evidence that microplastics are affecting nitric oxide production?
Yeah, like microplastics are a huge problem. And, a lot of the dangers are completely independent of nitric oxide production. But anything that's a toxin inside the body that's interrupting with the normal flow of electrons for biochemistry to occur, for example, to make nitric oxide, that enzyme, it's a 5-electron oxidation step. So that's a very complex biochemical reaction. So what that means is you got to have, a donor of 5 electrons. And if you're overexposed to electron stealers, there's not enough electrons to allow that flow through that enzyme to make nitric oxide. And so microplastics, disrupt the normal conformational change of enzymes that lead to the catalysis of whatever job they have to do. And it leads to, hormone disruption, I think, is the biggest contributor to the pathology of microplastics. And a lot of these are, estrogen mimetics. You got guys with man boobs and gynecomastia and, the feminization of men. And I think a lot of that can be explained by overexposure to plastics. So those things are toxic at many different levels, not just at the level of production of nitric oxide.
Yeah. I saw a chart on your conversation with Stephen Bartlett, and it showed the kind of age, and we can probably pop it up on here on the edit actually, and we can show like the production decrease. Well, are there any parts of the planet where it tends to be better or worse? Sometimes you hear like maybe in certain regions, people are better at, I don't know, I'm thinking standard Mediterranean diet and all that sort of jazz. So is there certain areas where people just generally producing more nitric oxide than others, or not so much?
No, there's several. I mean, certainly the blue zones, it seems to provide an environment that's conducive with sufficient nitric oxide production. Last month I spent 8 days in Italy, and very aware of that. The food we eat, the environment, the wines, the spiritual, the religious aspect. I mean, all create an environment that I think promotes longevity. Certainly Costa Rica. I spent time in Costa Rica there, and there's it's a pristine environment. Again, food locally sourced, free of pesticides, herbicides, and the common denominator is that it's a good, clean diet, and people are walking and moving, they're active. And then in 2007, we published in Proceedings of the National Academy of Science that people who live at altitude, in this study, we measured the people that live at Tibet, which is 12,000 feet above sea level, or 4,000 meters. have 50 to 100 times more nitric oxide output than people who live at sea level. So this low oxygen environment, people go to altitude, and many people get altitude sickness, high altitude pulmonary edema, and many people die from this. But yet the natives up there are the ones who lead the expeditions to the summit of Everest at 25,000 feet, right? And they don't get sick, they don't get altitude sickness, and they're extremely healthy. So what we published in that paper and what we discovered is that if you're exposed to a low oxygen environment, your body responds to hypoxia by increasing nitric oxide production. Because you need oxygen to make nitric oxide, and you need nitric oxide to deliver oxygen to every cell in the body. So if you have good endothelial function and you train at altitude, which is why all athletes train at altitude, because it's not just an erythropoietin, an increase in hemoglobin and hematocrit, but it's increasing nitric oxide production. So if you're a good, well-trained athlete, you go to Mexico City, Colorado, for example, in the U.S., you train at altitude, your body adapts by increasing nitric oxide production. Now, and then that stimulates more mitochondria, more efficient ATP production from the mitochondria. Now you become a well-trained athlete and optimized for performance. But if you take an unhealthy person to altitude, their body can't make nitric oxide, they don't adapt, they develop severe mountain sickness, many cases high altitude pulmonary edema, and many people die or have strokes or develop debilitating symptoms at altitude. And all that can be explained by the ability to produce sufficient nitric oxide to adapt to lower oxygen environments.
A lot of people talk about the benefits of CO2, and I know Patrick McKeown very well, who had you on the podcast recently. Yes. And so a lot of the work I've seen is CO2, and nasal breathing is really good for keeping CO2 levels at the right level. When we go to I interviewed a guy a little while ago talking about when he went to Everest, or we go to high altitudes. He was saying there's an issue with CO2 because people are over breathing, maybe 100 breaths a minute, 50 breaths a minute, and they're dumping CO2 and getting confused. I would love for you to could you walk us through the complex relationship with CO2 and nitric oxide? Because it feels like, or it sounds like, what you're describing is what a lot of people are giving CO2 credit for. And I don't know if it's like they're both doing similar things, or actually CO2 is taking too much credit for a lot of the work that nitric oxide is actually doing. Yeah.
Well, the cardiorespiratory system is a 3-gas system. For years we thought it was only oxygen and carbon dioxide, and that this well-described what we call the Bohr effect, right? Which regulates oxygen delivery, carbon dioxide uptake in the periphery. So hemoglobin is an enzyme or a protein that has to undergo a conformational state. So when it goes from the arteries to the veins, in the small blood vessels, the capillaries, and the hemoglobin is a very sensitive molecule. When it senses that the blood oxygen saturation, the P50, it undergoes a conformational change from what we call a relaxed state to a tense state, and delivers oxygen, picks up carbon dioxide, goes to the pulmonary circulation. We release CO2 in the exhaled breath, and we pick up oxygen. So this is the well-known Bohr effect, known to be modulated by CO2, or carbonic anhydrase, and 2,3-DPG. Those are what regulates the allostery of hemoglobin. But in 2015, Jonathan Stamler discovered that nitric oxide is the primary regulator of oxygen delivery and oxygen uptake. So the example you give, if you develop metabolic acidosis, we're producing too much CO2, carbonic acid, and that lowers the pH and causes metabolic acidosis. And then you start to develop, respiratory illness, metabolic acidosis, and really people get really, really sick. The buffering capacity of that is, number one, you got to be able to produce nitric oxide, because nitric oxide bound to the cysteine residue on hemoglobin is really what controls oxygen delivery and CO2 uptake. And then in the pulmonary circulation, unlike any other vascular bed in the body, if we start to get hypoxic, if certain regions of the lung become hypoxic and there's not adequate oxygen exchange, then the body shuts off blood supply to that particular region of the lung, and it usually starts in the lower airways. So now we have less capacity of the lungs to oxygenate the tissue. We get a rise in CO2, we get the acidosis, and this perpetual feed-forward cycle. So as long as our body can make sufficient nitric oxide, we're dilating the pulmonary arteries, we're leading to sufficient oxygenation, and we're matching ventilation to perfusion. And that's the key to respiratory health and really athletic performance and adaptation to altitude. We have to maintain pulmonary perfusion so that now we have all regions of the lung oxygenating the blood, making nitric oxide. The blood's able to go to every cell in the body, deliver oxygen, pick up CO2, and prevent the metabolic acidosis and maintain adequate ventilation to perfusion. And without nitric oxide, none of that happens. You get an increase in CO2, you develop metabolic acidosis. And, that's what we saw during COVID. The hypoxemia, the metabolic acidosis, and, the death of millions and millions of people that could simply be corrected by giving nitric oxide.
Wow. So with a breathing technique, are you familiar with the Wim Hof method or these sort of hyperventilation techniques? So somebody might do, 90 big breaths, and they'll get woozy and a little bit lightheaded, and different things will happen. And my understanding is we're dumping CO2, and as part of that process, there's a vasoconstriction that's happening, and we're reducing blood flow by around 20% to the brain. So is that restriction and constriction happening more because of the nitric oxide or the CO2, or both? What's happening when we hyperventilate and we feel that tightness and blood pressure can shoot up, I believe, as well?
Well, this whole concept of intermittent hypoxia or intermittent ischemia is an adaptive response. So it's a brief kind of insult to the body. And so the body always responds to insults, right? So if you go back 30 or 40 years, it was first recognized that if intermittent ischemia, so if we restrict blood flow to the brachial artery for 5 minutes, and we just put a blood pressure cuff for 5 minutes and completely occlude blood flow into the brachial artery, you could protect the heart from injury from heart attack. So it's a cardioprotective, it's intermittent ischemia. And so that intermittent ischemia tells the body, I've been deprived of oxygen for 5 minutes. I need to adapt and start to bring in mechanisms that will prevent a loss of oxygen in the future, if this occurs in the future. And I think what's happening in the Wim Hof is we're creating an environment of low oxygen, high CO2, and the adaptive response to that is the body increases mitochondrial biogenesis. It improves nitric oxide production. So now that we can be more resistant to hypoxia or ischemia and not suffer damage from it. But, if your body's not primed and optimal, some people shouldn't do this Wim Hof breathing, right? Because if their body's not adaptive, if it's not fit to adapt to that brief insult, it could cause some damage. But I think as an adaptive mechanism, I think it can be very effective. And it's the same thing I tell people about cold plunging. If you're got congestive heart failure, you don't have a strong heart, the last thing you need to do is jump into a bath of ice water, because it's going to put extreme stress on your body, and your body's not able to deal with it. I think the similar approach could be, for deep breathing exercise.
Yeah. Okay. So back to the humming then. So if we assume that the person can produce some nasal nitric oxide, or they can produce nitric oxide, when we're humming, is there going to be a saturation point? Like, if you are producing nitric oxide, what is the benefit of humming and bringing more of that nitric oxide into your body? And is there a point where you would empty and that wouldn't work as well?
Yeah, there are data and studies out there showing that there's a depletable source of nitric oxide that's humming. So when you first start to hum, you start to see kind of a peak of nitric oxide that we can detect in the exhaled breath. And then if you stop and then you start again, there seems to be a dampened effect. And so with each humming, so I think what's happening is there's a kind of a mobile source of nitric oxide that we can be deployed with humming. And then we've got to replete those over time. So the more you hum, the more dampened the effect of nitric oxide release is. But if we give nitric oxide, for example, if you take our lozenge and we replete these labile stores of nitric oxide, these stores that are mobilizable with humming, then we can increase those stores and increase nitric oxide release through humming. At least that's kind of the theory behind it, and I think that theory has been played out. But number one, you have to make sufficient nitric oxide to titrate up these stores that can be released with humming. And then, humming can, it's relaxing. It's, during yoga and all these different, time-proven mechanisms or kind of holistic health approaches, employ that. And just like deep breathing can lower exercise and reset the autonomic nervous system and activate the parasympathetic nervous system. I think humming can do similar things. And, part of that can be explained by nitric oxide.
Okay, cool. And when you are doing the humming exercise, I just want to stick on this for the last couple of questions, and we breathe in that air with that increased load of nitric oxide. Like, what is that actually doing? Are there any measurable benefits of that coming into the lungs?
Yeah, so you can do, and we've done this in the cardiac cath lab, looking at right heart catheterizations, looking at pulmonary pressures. So in a normal, healthy person, if we're making nitric oxide, when we do nasal breathing, that nitric oxide is released. It travels down along with oxygen, and it's dilating the lower airways. It's diffusing into the pulmonary circulation, dilating the pulmonary arterioles, and we're getting adequate, perfusion and ventilation and tissue oxygenation.
Okay.
In patients with right heart failure, for example, or COPD or pulmonary hypertension, part of the problem is they're not making nitric oxide, so their pulmonary pressures go up. And we can measure that through some catheters in doing a right heart cath and look at pulmonary pressures. And if we give them nitric oxide, we can see pulmonary pressures come down. And then you can start to see, opening up the pulmonary circulation and matching ventilation to perfusion. So even in patients with COPD, emphysema, respiratory illness, nitric oxide is delivered into the airways if it's produced, and it's dilating, relaxing the smooth muscle of the bronchioles, smooth muscle of the arterioles, and leading to better perfusion and better oxygenation.
Mm. And there's a Dr. Buteyko, I think you might be familiar with his work back in the 60s. He came up with a cupping exercise where you put your hands around your nose and you'd breathe slowly. And I think the theory is that you'd be breathing in a little bit of extra CO2 back into the system and help keep the system moist and stop it from dehydrating and slow the breath down, and a little bit extra CO2 for CO2 sensitivity. I would love to just get your thoughts. I know this hasn't, maybe it's been tested, so maybe you can answer this, or just to get your initial thoughts. If we hum into cupped hands and then we're slowly breathing that back in, do you think we would capture any of that nitric oxide that we've hummed out? Because I feel like we lose a lot of it on the hum out, and then obviously we breathe back in again. So just your thoughts on some cupping and some humming, what that might or might not do.
I don't know if it's ever been tested. I've never tested it if it's in the published literature, but here's the challenge. Nitric oxide, once it's produced, either through humming or in the lining of the blood vessels or in the airways, it's gone in less than a second. Well, intravascular, it's a half-life of about 2 milliseconds. What that means is in 2 milliseconds, 1/5 of a second, 50% of the nitric oxide that you produced is now gone. In an extravascular environment, like in the airways, nitric oxide can stay around as a gas for several seconds, but it's still on the order of seconds. It's certainly not minutes or hours. And, there's enzymatic systems, there's metals that can change nitric oxide metabolism. The dioxygen reaction, when nitric oxide reacts with oxygen, is really a slow reaction. And it's second order to nitric oxide. And typically we have much more oxygen around than we have nitric oxide. So we really don't worry about the dioxygen reaction. And that's why inhaled nitric oxide can work, because you deliver nitric oxide gas with oxygen, and that reaction is so slow that it never really occurs. And we can deliver it directly to the airway. So thinking through this, I think we can probably do that because we know we can safely and effectively deliver nitric oxide gas through a nasal cannula. So if we're making it through humming and then rebreathing it through cupped hands, it should be delivered to the airways, to the lower airways and to the pulmonary circulation.
Okay. And
provided your body's making sufficient amounts of it, right?
Gotcha. That makes sense. And I'm just curious if there's any link then between nose breathing, humming, and erectile dysfunction. So if someone's got erectile dysfunction and they were mouth breathing and they switched to nose breathing, would that make any difference? Could you just walk us through that little bit?
It could, but we first have to focus on restoring the function of their enzyme, their nitric oxide synthase enzyme. And we understand the enzymology to the extent that we know how to restore the function of that enzyme. But if we don't fix the enzyme, the function of the enzyme, and they switch from mouth breathing to nose breathing, they're still not going to make any nitric oxide to overcome their erectile dysfunction. So we have to focus on fixing the enzyme so that now the blood vessels, the endothelial cells that line the corpus cavernosum of the penis, can actually produce nitric oxide, get engorgement, and then we can restore the oral microbiome that's also responsible for production of nitric oxide, that we can improve blood vessel dilation and erectile function.
Mm.
And their breath is going to smell better if they're not mouth breathing, which is better
Yeah.
for their partner.
And no infections in the mouth. Let's talk about the mouth biome then, because this is really interesting. So I've only just recently discovered like coconut pulling. I don't know if you're familiar with that term. It's like basically using
Oil
coconut
pulling,
as. So I don't know, it'd be good to get your thoughts if that's actually making things better or worse. But I used to years ago use mouthwash. I years ago would smoke and all these terrible things. And so what's going on in the biome? How can we recover the microbiome of the mouth to help produce more nitric oxide?
Well, we first have to understand these communities of bacteria that are responsible for producing nitric oxide. Then we had to understand what do these bacteria need to respire on in order for them to maintain adequate populations and normal metabolic activity. So we certainly understand that to a pretty good degree today, but anything that's antiseptic, that destroys the microbiome, and that's going to be fluoride in your toothpaste. You're in the U.S., 73% of cities put fluoride in their drinking water, and not only drinking water, the water you bathe in, cook in, and drink. So those are and then sugar. Sugar completely disrupts the oral microbiome. So sugar, any food that's high in sugar can destroy the microbiome, lower salivary pH, and change the normal environment or ecology that leads to oral dysbiosis. So, mouthwash, bad news. We have to support the microbiome and not destroy it. By the same argument that no one should take an antibiotic every day for the rest of their life because it causes dysbiosis, it causes systemic disease, we can't take an oral antiseptic like in mouthwash or exposure to fluoride because it's destroying the microbiome and it's leading to systemic disease. So I tell people, if you're using fluoride toothpaste, you have to switch to a non-fluorinated toothpaste. If you have fluoride in your water that's supplying your house, you have to get a home filtration system to remove the fluoride, the chlorine, all the drug metabolites that are found in municipal water. And then, stop using mouthwash. I mean, it's very clear to me that, we and others have published that if you use mouthwash, it destroys the microbiome, destroys nitric oxide production, and we see an increase in blood pressure. And because high blood pressure is the number one driver for cardiovascular disease, which remains the number one killer of men and women worldwide, we have to better normalize blood pressure. And what we're finding is that if we can, people who have resistant hypertension, meaning that they have high blood pressure, they go to their doctor, they put on a prescription medication, but you have 50% of the people that are prescribed medication don't respond with better blood pressure. And now we can explain that because their hypertension is due to nitric oxide deficiency. So ACE inhibitors, ARBs, calcium channel blockers aren't fixing that, so they don't respond with better blood pressure for those medications. So now if we target the microbiome and use that as a focus for nitric oxide production, we can now manage blood pressure. So I tell people, okay, if you have high blood pressure, are you using fluoride in your toothpaste? Okay, get rid of fluoride. I just launched a fluoride-free, nitric oxide-friendly toothpaste. If you're using mouthwash, stop. If you're on antacids, wean off of them. And if you do that, what we're finding is 30 days later, they come back and their blood pressure is lower and it's more normal. And now you can start having the conversation of weaning people off prescription medication, which should be the ultimate goal of medicine. If the body is optimized, there's no need for drug therapy. And when you address root cause of disease, there's no need for drug therapy because the human body is much smarter than we are, and drugs have never healed anybody. Physicians don't heal anybody. It's the body heals itself. We just got to get out of the way.
Yeah. I feel like increasingly the modern world is trying to get us. There's so many things like the chlorine, like the mouthwash. You said something really interesting about antibiotics a second ago, so I'd love if you could just dig into that a little bit more, because I went through a period like, right, I'm never taking antibiotics again. I got an ear infection. I was in Costa Rica actually, and I was in a pool and I got an ear infection. I was like, I'm not taking any antibiotics. I'll let my body sort it out. And it got worse and worse and worse. My ear closed up and I had to go to the A&E, the emergency room, and they had to do something on it to open it up again. I was like, you should have taken the antibiotics. So then I was like, okay. And I took them and it got better. But I was really annoyed at myself because I thought, no, my body can heal everything. So is there a time and place where it's necessary, or are you very much like, no, no, there's other things you should be doing instead of
No,
antibiotics?
absolutely. I'm like you. Look, there's a time and place for
Okay.
antibiotics. If I've got a serious bacterial infection, then I want an antibiotic because if you have a compromised immune system, this could lead to septicemia and end organ failure and death. So there's a time and place for antibiotics. The problem today is, physicians are prescribing antibiotics for viral infections. It makes no sense. And we're overusing these. There's in the US 100 million prescriptions written every year for antibiotics, and many times unnecessarily. But antibiotics clearly, they're not just, different classes of antibiotics are targeted toward, gram positive, gram negative, different classes of bacteria. But there's always collateral damage. They're always causing dysbiosis, always causing oral antibiotics clear effect on the gut microbiome and causing systemic disease. And so I think we have to do a better job of, and here's what we're finding. If you have good microbiome, good gut microbiome, good oral microbiome, your immune system is pretty strong, and typically people don't get sick. And for me, I haven't been sick with a viral or bacterial infection in more than 20 years. Even all through COVID, I never got sick from COVID. I never got COVID. I never had symptoms of COVID. Even I live on a ranch, got an 800-acre working ranch, and I'm always getting scrapes and cuts and banged up, but my body heals, and it's because I support the microbiome, and I haven't taken an antibiotic in decades. But again, if I need it and I get a severe infection, then I want to have access to antibiotics. But I think we have to be judicious in how we use these, and making sure it's for a very short period of time to eradicate the infection. But then you got to take steps to repopulate, restore the normal good flora so that we don't get sick and don't get infections, because the good bacteria keep the bad guys at bay.
Yeah. No, thank you for sharing that. I'd like to talk about vitamin D, daylight, artificial light with you, and nitric oxide production. So is there any correlation or any evidence about vitamin D levels in nitric oxide production?
No, for sure. There's a very strong correlation, not just a correlation, the mechanism of vitamin D activates and stimulates nitric oxide production. So in people who have low vitamin D, they're typically low in nitric oxide because it's one of the natural agonists and stimulants and activators of nitric oxide production. And so we see this, in African Americans, known health disparities of African Americans, typically because of their dark pigment, have lower vitamin Ds than other ethnic groups. And we know that African Americans suffer from severe health disparities, higher rates of heart attack, stroke, certain cancers, hypertension, kidney disease. And all that can be explained by a lower nitric oxide production. And it's not just lower vitamin Ds, it's a G6PD deficiency, it's overexpression of NADPH oxidase, it's diet, lifestyle, all those contribute to it. But vitamin D, extremely important in being a natural activator and stimulator of nitric oxide production. In the US, they say normal is 50. I don't want to be normal. If normal is, compared to our peers, I want to be optimal. So we need to have vitamin D levels, blood levels of 80. And I think if you take a vitamin D supplement to supplement, but, more importantly, if you get adequate sunlight exposure, 20 to 30 minutes a day, then it's natural vitamin D production and activation. And, I'm a big proponent of first sunlight. I get up before the sun comes up, and I usually, get full sunlight exposure, first sunlight, 20, 30 minutes a day. And then I'm out on the sun. I don't wear sunscreen. I typically don't wear sunglasses because my body needs that exposure, and it resets our circadian rhythm, affects our pineal gland, and extreme benefit of sunlight. The worst thing you can do is use sunscreen and not get any sunlight exposure. And yet, that's what we're programmed to do. When you go out in the sun, put on SPF 195 or whatever the shit is they put on your body full of toxins.
Yeah, no, we're deep down this route. I got my blood work done in January of this year, and my vitamin D was 30. And so I made a conscious decision this year to get outside and supplement. So I've got a standing desk in the garden. We're in England, so it's obviously not great weather here. But we've been abroad as well. Often I've got my shirt off. We've had really good sun this year, like really, really good. So I've been out for hours. And I got my blood work done about 4 weeks ago, and it had gone from 30 to 50 in 6 months. And I was shocked. I was like, wow, that was a lot of work to get that small small jump. So I'm glad you mentioned 80. Is 80 optimal, or would you go for would you say optimal is a different number from 80?
No, I think the data tell us 80 is sufficient, because the problem is if you take too much vitamin D, it can mobilize calcium. And, you don't want to mobilize calcium from the bones and putting in the lining of the blood vessels. So I think what I recommend is, take a high quality vitamin D, but with a D3K2 to kind of balance calcium metabolism, because too much vitamin D can mobilize calcium and lead to some problems.
Mm.
Lead to
Now,
bone, osteoporosis and the demineralization of bone. So we have to be careful.
okay.
But D3K2 at the proper ratio is adequate.
Okay. And on the flip side, then we've really messed our world up, and we've gone from being in this beautiful outdoor sunshine all the time, and then we've gone indoors into these dark, gloomy environments. And then to make matters worse, we bathe ourselves in artificial light. Now, are you aware of any issues with artificial light, or not so much?
Now, I've been following this for years and didn't really put that much credence in it. But, I go to a lot of these medical conferences, biohacking conference, and people sell them the blue blocker shades, and many companies give me things to try, I guess because they think I'm an authoritative voice. But here's what I did. I took these blue blockers, and when the sun goes down, I would wear it. And then, I don't watch a lot of TV, but if something's on at night or I'm trying to answer emails on my computer screen after the sun goes down, I wear these blue blocker glasses, and immediately I noticed my quality of sleep completely changed. So now when the sun goes down, or if I'm in airports or anywhere there's artificial light, you may see me wearing these glasses to block the harmful blue light. But if I'm outside during the day, I typically don't wear any type of sunshades. And I used to be really sensitive to light, where I'd almost have to wear sunglasses. But when I stopped and allowed my body to adapt to them, I can go out and, first thing in the morning, look directly into the sun. It's not that bright, not that damaging. But, used to, I couldn't do that. But I think it's exposure to sunlight, especially through the eyes. What I've noticed is I just spent 8 days in Turks and Caicos, and, we don't wear sunscreen, but we're out in the sun 4, 5, 6 hours a day, fully exposed, and we don't get sunburn. No sunscreen, because if we expose our body, our eyes directly to the sunlight, it's protecting us, because it's telling our body internally, hey, you're exposed to potentially damaging rays. We're going to put these protective mechanisms in place. But you can't overdo it, and you can't be foolish either. I mean, I wouldn't recommend somebody staying 8, 10, 12 hours fully exposed to the sun, because you will get burnt. So for me,
Mm.
if I start, rather than putting on sunscreen, I just put a hat on and cover my skin. That's the
Mm.
best sunscreen there is.
Yeah, yeah. I heard that advice years ago. I was like, right, I'm immune to sunburn, and I've got very Irish skin, and I went outside and burnt the crap out of myself. But yeah, I'm much more sensible with it now. So yeah, so we are big proponents of the light blockers. I use them a lot.
Yeah.
I interviewed a neurosurgeon a little while ago, Dr. Jack Cruz, and he was talking about
Brilliant.
um he was calling LEDs like an alien sun. And I forget exactly what he was going into, but he was saying he believes that it's very damaging to our skin. So I was just curious if there was anything that you'd come across where LEDs were maybe messing up on nitric oxide production.
I'm not. I have an LED light bed that emits certain like 5 different wavelengths of light. And we've done clinical studies on people lying on an LED bed with high blood pressure. And we see within 1 week, 3 sessions on an LED bed can lower blood pressure by sometimes 20 millimeters of mercury. We think nitric oxide is playing a part of a role in that, but it's also, there's a thermal aspect of it that's leading to uh, smooth muscle relaxation and blood vessel dilation. But I mean, that's probably completely different than the artificial LED lights we have in light bulbs. Those are therapeutic, and it's very specific wavelengths that's dialed in. I think there's 5 different wavelengths in that technology. But no, I think, look, light's extremely important, and looking at the efficiency of electricity, and I think there can be damaging effects to that, and people just need to get out and get a source of natural light rather than being cooped up all day in artificial light.
Yeah, no, I agree. And this last bit on light is red light therapy. This might be what you're talking about with the LED beds, but I've got a really nice red light therapy device. It's one that kind of bends around your arm. You've probably seen it at the biohacking
Yeah.
events. You see these Juve boxes that are kind of a bit further away, and I notice a lot of them talk about nitric oxide being one of the benefits of having red light therapy. So could you just talk to us a little bit about your knowledge of that?
Yeah, so it's very clear that certain wavelengths of light and some frequencies in the infrared spectrum can release nitric oxide from metals. So part of the work I did 25 years ago was trying to figure out when nitric oxide's produced, where does it go? What does it become? Because we know that it's gone in less than a second. But the signaling aspects of nitric oxide last much longer than 1 second. So what we found was that nitric oxide can bind to metals, really any redox active metal. The primary target is like heme iron and proteins, and hemoglobin, for example. And so when the frequency of infrared is a frequency of which can knock nitric oxide off that metal. So if we make sufficient nitric oxide, we've got these what we call photolabile stores. Again, we published on this probably in 2002, 2003, where we could activate blood vessels with certain wavelengths of light and lead to blood vessel relaxation that was dependent upon nitric oxide. And so these photolabile stores are dependent upon the body's ability to produce nitric oxide. So if we have adequate nitric oxide, we titrate up these photolabile stores. If we can't make nitric oxide, there's less nitric oxide bound to metals. There's less nitric oxide to be released through red light technology. So the best case scenario is if we take nitric oxide or we have an optimal nitric oxide production and we're exposed to red light therapy or direct sunlight, then those frequencies are releasing nitric oxide bound to metals. So we're liberating stored amounts of nitric oxide that can be vasoactive, that can activate mitochondrial biogenesis, that can turn on telomerase enzyme to prevent telomere shortening, that can even mobilize stem cells. Nitric oxide is the signal that tells our own stem cells to mobilize and differentiate, to repair. So if you have a sunburn, you can slough off the damaged cells and replace them with cells that work properly. So yeah, red light therapy is efficient, and it's not singly a nitric oxide phenomenon. I mean, it's activating mitochondria. They're chromophores in the mitochondria that lead to activation of ATP production. But in terms of nitric oxide, it's dependent upon the repletable sources and stores of nitric oxide that can be activated by red light therapy.
And is there any benefits to localized light treatment? So, you see some influencers online getting the sun on their genitals, or you see red light therapy over the lungs. Is there would that make a difference to those areas if they were being concentrated with those sorts of light waves?
I think certainly for wound healing, we've done a lot of
Okay.
work in diabetic ulcers and, paraplegic or quadriplegic decubitus ulcers, pressure sores. And when we're treating a lot of these sores with nitric oxide, because I think nitric oxide's completely uh, will overcome these non-healing wounds. And in America, 65,000 Americans die every year in nursing homes from infected wounds. So nitric oxide is the key to wound healing, because typically non-healing wounds are infected. If we put nitric oxide in the wound bed, it kills the pathogenic bacterium, as we discussed. But most non-healing wounds are hypoxic. There's not adequate blood supply to that wound, and that's why it doesn't heal. So nitric oxide will cause a hyperemic response, get blood flow to the wound, and we see wounds heal remarkably. But part of what we also do is when we treat with nitric oxide, we put red light therapy directly over that wound in that wound bed. And that seems to accelerate the healing of that wound bed. I can explain it from a nitric oxide perspective, but it's probably doing more. Again, the red light is probably contributing to vasodilation, activating mitochondria, cellular metabolism, and perhaps tissue granulation and tissue growth. But certainly the red light therapy is not going to have as much clinical benefit without nitric oxide. So we throw everything we can, and I've healed my dad's, paraplegic for 40 years and dealt with chronic wounds for many, many years. And we've healed, 4-year-old non-healing wounds, primarily with nitric oxide, but I used red light on it. I used ozone insufflation, and we used stem cells.
Wow.
But the thing that moved the needle the most was the nitric oxide.
And what is that? Can you just describe to the layperson, like, what, when you say nitric oxide, are you like spraying it onto the area? What is it? Is it a cream? What does it look like?
Well, this has been an evolution because, again, nitric oxide is a gas, right? It
Hmm.
can't deliver it in a liquid or a capsule. It's a gas that we have to produce. So years ago, what I was doing before we developed any topical technology was I was just making a gauze that I would, in treating my dad specifically, I would do a wet to dry dressing usually twice a day, but I would make a nitric oxide releasing gauze that I would put in there, and over the, when it became moist inside the wound bed, it would release nitric oxide. So then when we healed that wound, I go, well, all the wound care docs were like, you have to bring this to market. And so we developed a topical nitric oxide. It's a dual chamber. Because nitric oxide is a gas, we have to keep these actives separate. So in this dual chamber, actually here, I have one here. It's two chambers inside this cylinder here. When you mix these two together and apply it on the wound or on the body parts, it'll produce nitric oxide, diffuses into the tissue, dilates blood vessels, recruits capillaries. So when you apply that, you can immediately see the skin turn pink, indicative of an increase in blood flow. So you actually see this product working right before your eyes, and it's incredible at wound care, and not just wound care, but skin and beauty and fine lines and wrinkles and improving the tone, texture, clarity of the skin. And we've got 5 published clinical trials on that product as a consumer product for a number of dermatological issues. But yeah, you have to, if your body can't make it, then we got to do it for you.
That's cool. There's a CO2 guy that I talk to a lot. His name's Anders Olsen. He was in James Nestor's book Breath, if you ever came across that book, or James.
Yeah.
And he was the other guy that went through the mouth and nose tests. I don't know if you know, James did a 10-day experiment at Stanford where he breathed only through the mouth and then only through the nose, but I digress. Anders, who's this kind of Swedish CO2 inventor, he's got like a CO2 suit that he wears, and he fills it up with CO2. He's also got a CO2 mask, and he's breathing that in with, it calls it, I forget the name of it now, but he shares a lot of pictures of CO2 therapy for diabetes, and in particular people that are starting to lose parts of their feet. And so they'll put their feet in these like fizzy bubble baths, and after about 6 weeks their feet are almost healed. So I'd love to get your thoughts on that as from the nitric oxide perspective, what might be going on there.
Yeah, again, I think it's this concept of hormesis, creating an environment that the body adapts to. My concern with that approach is that people with severe, diabetic ulcers, diabetic foot, diabetic neuropathy, is their body is not able to adapt to that insult or that stimulus. So their adaptive mechanisms are compromised, and that's part of the reason why they have a non-healing foot ulcer. But whether it's a decubitus ulcer, a foot ulcer, what we're finding, and again, this is my own bias and really focus of research, is if we give nitric oxide systemically to dilate the systemic circulation and open up the microcirculation internally, and then we apply nitric oxide topically, then we're healing this wound from the inside and out. And nitric oxide is the key to wound healing because, again, it's killing the infections, the Pseudomonas that's found in most non-healing wounds, and it's causing a hyperemic response. So now we're taking a hypoxic wound bed and getting blood flow to it, oxygenating that tissue, mobilizing stem cells, and getting tissue regrowth. So, I mean, CO2 may work. I never argue with clinical data, but what I try to do is, number one, figure out what works and then figure out why it works. Because when we understand what works, understand why it works, we can actually make it better. And nitric oxide, I think, is the key to wound healing. Because people who have non-healing wounds are the people who can't make nitric oxide. If we give nitric oxide or restore the body's ability to make it, wounds heal.
Wow. It's very cool. It's very, very cool. I'd like to talk a bit about diet with you. So you mentioned leafy greens in other podcasts and in different things that you've published. Could you talk about like specifically like what is that? Because I think spinach and kale and things like that. So like what give us the nitric oxide diet. What would that be? What should we exclude? I know you've mentioned sugars. I'd love to get your thoughts on like artificial sweeteners and what we call UPF, ultra processed foods. So like what's out and what should we be increasing more of in this NO diet?
Yeah, the big culprit and contributor to disease is sugar, as we all know. Sugar's the poison, sugar's the toxin. Completely, resets your metabolism, causes oral dysbiosis, causes endothelial dysfunction. So that's the big thing. And then in terms of, then again, we have to eliminate fluoride and mouthwash, or else nothing in your diet is going to work. So you can eat a straight vegetarian, straight vegetable diet, but if you have fluoride in your toothpaste, fluoride in your water, if you use mouthwash, you do not get a nitric oxide benefit from that diet. So we have to kind of clean up the landscape and allow the body to be primed to make nitric oxide. Now, if you eliminate fluoride, you have a good oral healthy microbiome, and your stomach can make stomach acid, then the perfect kind of nitric oxide diet is a lot of good quality protein, whether it's plant or animal, good fats, the elimination of sugar, and then a nitrate-rich diet. And nitrate is primarily found in green leafy vegetables. But again, the challenge is, and we published on this in 2015, because the question we were trying to answer is if your body has the right oral microbiome, we have sufficient stomach acid production, how many sticks of celery would you need to eat to get nitric oxide, to manage your blood pressure? How many grams of spinach or kale or lettuce would you need to eat, or broccoli, to fuel this nitric, assuming that everything else was working? And so to answer that question, we here in the U.S., we went to 5 different cities. We went to Chicago, Los Angeles, New York, Raleigh, and Dallas. So kind of representative spots all over the Midwest, the East Coast, the West Coast, and the Deep South. And we bought the same vegetable from the same retail grocer, brought it back to my lab, and we analyzed it. And there was as much as a 50 to 80-fold difference in the nitrate of celery that we bought in Dallas compared to the we bought in New York. And so there's regional differences in the nutrient density of vegetables. And then the other revelation from that study was we compared organically grown vegetables to conventionally grown vegetables. And I don't know how it is in the UK or EU, but in the US, to get an organic label, no herbicides, no pesticides, but you can't add nitrogen fertilizer to the soil. That's a problem. Because without nitrogen in the soil, you can't assimilate nitrate. So organically grown vegetables have, sometimes 5, 10 times, 20 times less nitrate than the same vegetable grown conventionally. So that creates a huge problem and really an impossible feat to recommend how much celery, spinach, kale you need to eat to get enough nitrate. Because it depends on where you live and what vegetable you're eating. So it creates a problem. So what we have to do is, and I tell people that if your body can't make nitric oxide, then we make products that do it for you. So it takes the guesswork out. We know how much nitric oxide the human body makes, and we deliver that back in a product technology that we deliver.
So just talk us through that, because I'm intrigued. I don't know if you're selling this in England or not, but tell me about so it's like lozenges and different things. So walk us through that.
So again, nitric oxide's a gas.
Yeah.
And so I created this, what's called an orally disintegrating tablet. So an ODT. So this is a 1.4 gram lozenge. But basically you just put it in your mouth, and I designed it to have a resident time of 5 to 6 minutes. So over this 5 to 6 minutes, it's slowly dissolving. These actives are coming together, and I'm releasing 20 to 30 parts per million nitric oxide gas. So now if I put this lozenge in my mouth and I'm doing nasal breathing, I'm delivering nitric oxide immediately to my pulmonary circulation, dilating the bronchioles, improving blood oxygen saturation. We had a drug in phase 3 clinical trials for COVID using this same lozenge technology in a higher drug dosing, and we could find patients with blood oxygen saturation of 78. We give them the lozenge. Within 6 minutes, their blood oxygen saturation is 96. No oxygen therapy, no mechanical vent, breathing 21% oxygen in the room air. We've just improved their ability to take up oxygen, deliver oxygen, dilate the pulmonary circulation, match ventilation to perfusion, which was the problem in COVID patients, and we made them better. So we've shown this clinically, we've shown the safety, we've shown the efficacy. But we've had this product on the market for several years. We sell it in the UK. We're working on a UK distribution partnership now, but I think our goal is to get this product technology in the hands of people all around the world.
Very cool. So that person that was in the 70s and went into the 90s, like when they took that lozenge, how long would you expect them to stay? Would they then come back down again and would need to go back up with another lozenge, or would they stay there? How long would that last for?
It depends upon the severity of disease and the underlying comorbidities and their medical therapy. We treated over 500 really sick, high-risk patients during COVID from end of 2020 to the end of 2023. COVID changed, so we stopped the drug study because people weren't getting sick and going to the hospital. But what we found was that within 6 or 7 minutes, we could see blood oxygen saturation improve. And in our drug study, we were dosing them once every 12 hours. But that seemed to be sufficient because we armed them with a pulse oximeter that was tied to their smartphone, and we did remote telemonitoring or telemedicine monitoring of these patients. So when their blood oxygen saturation fell below 88, for example, we would get a text and we would notify them, hey, have you taken your study medication? If your blood oxygen saturation continues to fall, then you need to go to the hospital. What we found was in that particular patient, 78, the monitoring physician called them and they, have you taken your study medication thing? And of course they didn't. They were sick. So he takes his study medication, and then we're monitoring in real time on his blood pulse oximeter. Blood oxygen saturation within 7 minutes was at 96. So now he's not critical, doesn't need to go to the hospital, and he was completely fine throughout the rest of the study. But that, obviously, it was a double-blind placebo-controlled study. We knew that wasn't a placebo patient. Right? Placebo is not going to do that. But that patient then became more compliant on the regimen, knowing that he had to take the study medication every 12 hours to prevent that loss of blood oxygen saturation and hypoxemia, which would have put him in the hospital. They would have stopped his study medication. He would have continued to get worse. They would have put him on mechanical vent, metabolic acidosis, and he would have died. That was the progression of COVID and very predictable disease progression.
So with those lozenges, I'm really interested. So who are they for? Like, is it for everybody? And like, what would be the length of time that you suggest? Is it something like you're saying, like, no, you should really be taking this like a multivit every day for the rest of your life, or is it, no, you're an asthmatic, and if you have an asthma attack, you should take one? Or so, yeah, just walk us through that a bit.
Well, there's really only 2 people in the world who need nitric oxide or this product. Number one, it's if you're sick and want to get well, you need it. Number 2, if you're well and don't want to get sick, you need it. So if you fall in one of those 2 categories, I recommend it. I've been taking my product technology once, and this dates back 25 years ago when I first made discoveries on how to produce nitric oxide. And so I've been taking this product, a form of this product, for more than 25 years. And I take it not because I need it, I take it because I don't want to need it. Right? And even though I'm very health conscious, I eat a clean diet, I exercise every day, I get sunlight. I travel the world. I travel 150,000 air miles every year. I'm in an airplane every week, exposed to artificial light. But I take it prophylactically because I know that we live in a toxic world. Even given my best efforts, we still have compromised ability to make nitric oxide. So I take it every day. Then the other person is people who are poorly managed and living with chronic disease for decades. Look to nitric oxide as a means, not only a loss of nitric oxide as a contributor to their disease, but as a potential solution. Because as we discussed, your body cannot and will not heal without adequate nitric oxide. But the dosing regimen now becomes a consideration. So for me, I make a fermented beet powder that we position as a pre-workout, and I take that first thing in the morning because I work out in the morning when I wake up. And then I take the lozenge typically early afternoon or early evening. And for me, somebody who's taking it prophylactically, 1-2 a day is sufficient. But if you're an asthmatic, if you've got, cardiovascular disease, previous heart attack, diabetes, you may need 1 lozenge every 4 hours. And so we titrate according to symptomology and really trying to get physicians to use their best medical judgment on their individual patients. But 1 lozenge 2 a day is sufficient based on the pharmacokinetics and pharmacodynamics.
And what percentage of the population do you think have got nitric oxide dysfunction, if you had to guess? or based on what you've seen?
Greater than 90%.
Greater than 90. Okay.
Because and that's based on real data and observations. Because a recent study came out in America, and different parts of the globe may be different, but the American lifestyle seems to be conducive with chronic disease. But 9 out of 10 Americans are metabolically unfit. So when they eat like a high glycemic index, you see this insulin spike, you see this glucose spike, and it's the hyperglycemia, hyperinsulinemia that drives the inflammatory component of disease. So, and I think that's why it's so important to individualize therapy and diet and lifestyle. These continuous glucose monitors are pervasive now. These wearable devices are pervasive. So, I encourage everybody, wear a continuous glucose monitor for 30 days and see what you're doing, what you're eating that's leading to a sugar spike, and then avoid it. There's certain foods that I love to eat, but my body has a reaction to it. So I feel bad afterwards. So I know to avoid those, because the brief period of, benefit, or the, satiety and the from eating these foods, the risk and the way I feel afterwards completely, prevent me and staying away from these foods. And I think once you see it in real time, the spike in glucose and insulin, you're going to say, okay, I don't need to do that, because our health is our greatest asset. And the last thing we need to do is do things that are contributing to the demise of our own health. And as we start to understand all these things that many people don't realize, like, because we're conditioned, go to your dentist, get fluoride. If you want fresh breath, use antibiotic. If you eat foods that are toxic to you, your body tries to get rid of it. You get reflux. You take acid reflux to mask the symptoms. It's making people sick.
Yeah. Yeah. And just last bit on the diet. So you said nitrate is what we need in the foods. Is that right? Nitrate is that the component that then changes into nitric oxide? Or what's
That's
that
right.
process look like?
Yeah, it's
Okay.
inorganic nitrate. And, there's been not surprisingly here in the U.S., a misinformation and media campaign by the drug companies and big food, because you've probably heard, avoid cured meats, avoid nitrate bacon, hot dogs, lunch meat. Because 50 years ago, 70 years ago now, there was this concept that nitrate or nitrite could form nitrosamines. Nitrosamines cause cancer. Therefore, any nitrate cured meat product would cause cancer. So if A equals B, B equals C, then A equals C. Well, that never played out, because today we know that 85% of the exposure to nitrate comes from green leafy vegetables. Only 5% comes from cured and processed meats, and the other 10% comes from swallowing our own saliva from the endogenous production of nitric oxide. So if that were true, then we would know that vegetarians would have 10 times higher rates of cancer than meat eaters. And we know it's exactly the opposite, right? People who eat a vegetarian diet are typically protected from certain forms of cancer. So their biologically plausible mechanism in nutritional epidemiology does not work. And so that entire argument falls apart. In fact, we've argued for the past 20 years, nitrate and nitrite are indispensable nutrients. That if you're deficient in these nutrients, you become nitric oxide deficient, and it puts you at an advanced risk for the onset and progression of chronic disease. So we need to be, these meat companies, and I've consulted for Kraft, Oscar Mayer, and I go, look, you should be advertising this is a nitrite cured meat, nitrate cured meat. Not that it's nitrate free, because it's not nitrate free, it's not nitrite free. To have a cured meat product, it's dependent upon adding nitrite and nitrate. And you want that in there because it prevents botulism overgrowth, salmonella, foodborne pathogens, foodborne illnesses. You couldn't eat these products without them being cured.
Yeah, incredible, because contains nitrates is a big thing over here, because you want to
Yeah.
avoid that like it's the flu. Fascinating. Effects of sleep and nitric oxide production. Any connection there?
Just observations and feedback we get from people who have been taking our product for many years. It's always the top 3. And to me, it's surprising. The top one is they feel better energy, their blood pressure's improved, they have better sexual function, and then typically third, they say their sleep's better. I can explain mechanistically why they have more energy, activating mitochondria, why their sexual functions improve because they're leading to better vasodilation, But sleep, I don't have an explanation for mechanistically, but it's a clear response and reaction to people taking our lozenge. Deeper sleep, now with these wearables, their REM sleep, their D sleep is better, and the only thing they've said they've done differently is start taking the lozenge. So
Interesting.
it's an observation and a feedback that I hear all the time, but I have no explanation for it.
And on the other side of that, if somebody's having poor sleep or without the lozenge, does sleep quality itself affect nitric oxide production in mammals?
Absolutely, because it's during sleep that we repair and heal, right? And if we're not fully oxygenating, we're not making nitric oxide. If we're not making nitric oxide, we're not making stem cells or mobilizing stem cells. So we don't repair and heal during our sleep. And that's why, the mouth breathers are hypoxic. People with obstructive sleep apnea, lack of breathing, low oxygen. They wake up tired, they rapidly age. And look, sleep is probably the top of the list in terms of longevity, because without adequate sleep, you're not going to make nitric oxide, you're not going to oxygenate, and bad things happen.
Yeah, no, that's cool. Last couple of questions for you. I interviewed a sound healing, what do you call them, place in
Yeah.
Los Angeles a little while ago, and she's a scientist, and she actually went into sound healing, and she was very pragmatic about the whole thing. I'm just curious if you've seen any evidence around certain frequencies hitting the body to produce more nitric oxide.
Well, no, everything is about frequencies. The frequency of radiation, of sunlight, the frequency of humming we talked about, the frequency
Mm,
of sound. All of that. So frequency is, the distance between wavelengths, whether it's sound, whether it's light. There's healing frequencies, no doubt. But it's dialing in those certain frequencies that activate certain, signaling molecules. All we do is focus on nitric oxide, and certainly there are frequencies that activate and stimulate nitric oxide production, nitric oxide release. So now I've gone to some of these sound healing studios, the gongs, the different frequencies, and look, you feel it. It's relaxing. It's nourishing. So I'm a big believer in that, because I think at the end of the day, everything comes down to frequency and the flow of electrons, and we have to account for that.
okay, so yeah, I love those gongs, but for what I'm hearing, there isn't a certain gong you can smash and you're going to get a 10% increase in nitric oxide that you've seen yet. Okay, any
No, no,
benefit?
that would be interesting, but we've
Yeah,
never really studied it.
no, okay. Sauna, is that any benefits on nitric oxide?
Soda?
Sauna, like
Oh,
hot
sauna.
sauna.
Yeah, I'm a big sauna fan, an infrared sauna, because it's
Hmm.
providing two benefits. Number one, it's heating up, you're sweating, and we detoxify primarily through sweat, through breathing, through urination and defecation. And that's why
Hmm.
all of these, we have to have adequate hydration where we're urinating, we have to have good bowel movements, we have to have good breathing exercise, and we have to sweat, or else these toxins build up in us. But specifically, the infrared sauna, again, as we talked about, the infrared light therapy is providing benefit, mitochondrial activation, nitric oxide release. And when we release nitric oxide, we're dilating the blood vessels. So if we mobilize toxins, we're gonna, get better excretion of those toxins. So nitric oxide is critically important. And every morning, this morning I woke up at 5:30 and I sit 30 minutes in my infrared sauna at 170 degrees. And before that, I take binders. So if I'm toxic, I mobilize the toxins, I bind them, and I excrete them rather than just remobilize them and restore them.
Yeah, very cool. Is there anything we haven't covered that you wanted to cover?
This has been a pretty in-depth conversation. I've enjoyed it, but we've covered a lot. Yeah, I can't think of anything right off the
Okay,
head.
I think I've covered everything. That's been really, really fascinating. Just last thing, yeah. What's Viagra doing then? Is Viagra doing something to increase nitric oxide?
No, and I think that's a misconception, even by urologists and cardiologists. Viagra, the PD-5 inhibitors, do nothing for nitric oxide. How they work downstream of nitric oxide, right? So these are called phosphodiesterase inhibitors. So when nitric oxide is produced, it binds to an enzyme called soluble guanylate cyclase. Guanylate cyclase converts GTP into cyclic GMP. And then cyclic GMP is a second messenger that leads to calcium mobilization, smooth muscle relaxation. So these phosphodiesterase enzymes degrade cyclic GMP that nitric oxide turns on. So nitric oxide turns the switch on, figuratively and metaphorically, and then the PD-5 inhibitors keep it on because they're inhibiting the enzyme that breaks down cyclic GMP. But here's the key. 50% of the men that have been prescribed Viagra for the past 27 years don't respond with better erections. And the reason they don't respond is because they're not making enough nitric oxide to lead to an accumulation of cyclic GMP. So there's no cyclic GMP to prevent the breakdown of by Viagra. So that told us many years ago, erectile dysfunction is a symptom of nitric oxide deficiency. So you want to take 50% of the people that don't respond to Viagra, you give them a nitric oxide lozenge, they make nitric oxide, they increase cyclic GMP, the PD5 inhibitors prevent the breakdown, now they improve their erections.
Wow. Fascinating stuff. Thank you so much. This has been so interesting. And it's one of those things, like CO2 seems to get so much press, in the world I'm in anyway, and not enough people are talking about this. And so thank you so much for sharing this with the audience, because I know everyone's gonna find this so fascinating. Where can people find you if they want to connect, get the products, all that good stuff?
I'll plug my new book, The Secret of Nitric Oxide, Bring the Science to Life. And in this book, I just launched it a couple of months ago, but it tells the story of nitric oxide, really a lot of the things we discussed here over the past 70, 80 minutes. But it also tells my personal story of discovery and journey in academia. So I encourage you to read the book, nathansbook.com or Amazon, Barnes & Noble, wherever books are sold. And really, I want to educate and inform people, and I refer you to my YouTube channel, Dr. Nathan S. Bryan Nitric Oxide, because my goal is to educate and inform consumers to where they can make informed decisions and really start to make subtle changes that we talked about. Get rid of fluoride, stop using mouthwash, wean off antacids, do nasal breathing, get exercise, 20, 30 minutes of sunlight a day. And that's the content that we provide. And then those interested in product technology, it's N101.com. The letter N, number 1, letter O, number 1.com.
Wonderful. Thank you so much for everything. Hope to connect with you later down the line. And I can't wait for people to watch this and learn all this wonderful stuff. So Dr. Bryan, thank you so much for your time. And until next time, thank you for watching, everybody. Cheers.
Thank you very much.
Hey, thank you so much for sticking all the way through to the end of the podcast. I mean this so much. It means the world to me that you would watch this podcast, engage with it, and stick all the way through. So genuine thank you. You're the reason that we do these interviews. I love speaking to all these people and sharing this amazing info. I hope you got something from it. If something did stand out for you, then please put a comment on the YouTube video, because it'll help embed it for you, but it'll also give somebody else something that they can take away as well. And just while you're here, just a reminder that if you're exhausted, you've got any form of burnout, or you feel like you might be heading towards burnout, you've got some stress and anxiety, our 7-day burnout reset program is free for a limited time. And the only caveat I have, the only thing I'd say is, if you're going to do it, just do it. Don't delay, don't get it and then think I'll do it next month. Just do it. It's only 7 minutes a day, and I promise you'll feel different after 7 days. Each day I'm going to give you a different exercise to do. It's only a couple of minutes. At the end of the week, you will have felt all these different exercises that I've picked. I've chosen these amazing exercises, and you'll feel more relaxed, you'll feel calm, you'll hopefully sleep a little better, and you'll learn a few extra things about the breath as well. So the link's down below. We're normally charging nearly $100 for this. We're giving it away, just giving it away for free. So grab it while it is free, and I cannot wait to hear how you get on. If you're looking for something to do after this podcast, I would say get the course. I was going to give you a video to watch or something like that. Don't do that. Get the course, and I look forward to reading your comments below. All right, have a beautiful day, and just know that whatever state you're in right now, whatever led you to this podcast or this channel, know that there is hope out there, and that millions of people have shifted their lives, their mental health and their physical health, and you too can do the same thing. And I believe in you, and I trust you. All right, take care. I'll speak to you soon. Cheers.